Hi, my name is Jeff Hauk, and I'd like to acknowledge my collaborators from George Fox University, Dr. Kang, Dr. Philbrook, Dr. Jacobson, and Dr. Cuddyford, and we put together a clinical program called Beyond Bio-psychosocial, Optimizing Health Across Communities. Let's find out what this program's about.
So I want to start with a story. I'm an academic and a clinician and read lots of research studies every year. It's common to see questions in data that aren't the focus of a study. So I was reading some health service data that examine cost of restricted versus unrestricted access to physical therapy. But that's not what caught my attention. The study also documented that 80% or more of patients who had low back pain that might benefit from PT never accessed a PT provider. And this reminded me that I had read similar studies post-ankle sprains and ankle fracture. The fact that our good efforts were delivered to so few patients really bothered me, and I was motivated to make a change. This data and other forces in healthcare moved us, the George Fox University faculty, to redesign our community practice in 2017. We molded over and decided to just get started. Our new focus was to implement value-based and community-based models of care. As part of this move, we adopted the Patient-Reported Outcome Information System, or PROMIS scales. This presentation is mostly a story of how adopting and committing to new outcome measurements truly changed our clinical decision framework. Our goal setting became more social, our interventions became more psychosocial, our engagement with patients increased, and our visit count decreased.
What we learned is something others already knew. Our perceived value in healthcare system is defined by what we measure and hold ourselves accountable to change. This is a quote from the Harvard Business Review. Human beings adjust behavior based on the metrics they're held against. Anything you measure will impel a person to optimize his score on that metric. Questions for PT providers are, is it enough to measure physical function? What if we also held ourselves accountable as PT providers for psychosocial domains of health, with the overarching goal of optimizing individual and community health through movement? Our beliefs and identity as PT providers are changing. Our measurements and training in the biomedical aspects of movement have positioned us as experts in correcting movement impairments. However, new models of care are happening, including psychologically informed physical therapy, cognitive functional therapy, which more fully embraces psychological approaches, and hybrid approaches. What connects these new models of care are an emphasis on psychosocial domains of health, expanding our scope of practice to psychosocial measurements and treatments. New models of care are asking us to change from focusing on increasing physical ability to increasing participation in social roles. What this means for us as PT providers is delving into thoughts and beliefs and understanding how these match with physical work and lifestyle, with the goal to influence participation in social interactions with family, friends, work, and leisure, increasing physical activities. Key challenges for physical therapists include what biopsychosocial framework to use and what psychosocial interventions can we adopt. Criteria for including a new biopsychosocial outcomes framework include outcomes that are easy to use, valid, quick, and applied across many different kinds of patients. Second, outcomes that address patient needs, that are important to them and are prevalent for common problems. And then finally, outcomes that match patient needs and evidence-based treatments. These criteria are how we ended up with the PROMIS measures. The PROMIS scales were developed by the National Institute of Health to evaluate and monitor physical, mental, and social health. The scales are person-centered and apply to the general population and individuals living with chronic conditions. By using computer-adaptive tests that are valid and easy to use, this satisfies our first criteria. Measures of physical, mental, and social health that are important and prevalent to patients are also available, so these can be selected to satisfy our second criteria. And finally, by matching these measures to evidence-based treatments, we can satisfy our third criteria. Not only do these outcomes allow us to move to new health domains, they also require a shift to a new perspective clinically. First, the PROMIS measures are person-focused. This means instead of asking questions relative to pain or functioning of a particular joint or body region, all the questions focus on the person, never mentioning a specific health problem. This redirects the PT provider to affect change of the person rather than a joint or body region. Second, the PROMIS measures are normed to the U.S. population using data from the 2010 census. What this means is that the severity of the patient's health problem is now viewed relative to the functioning of others around them. This new look at severity turns out to strongly impact everything from who gets surgery to how many visits someone might need for physical therapy. So let's examine the normal distribution for the U.S. population for physical function. We can see that we obtain a bell-shaped curve with most people scoring near the U.S. average of 50. Our patient completes the questionnaires and obtains a T-score of 40, 10 points or 1 standard deviation lower than the U.S. average. We also note that a score this low only occurs in 16% of the U.S. population, and that typical functional limitations associated with this level of physical function are walking at 1 meter per second, difficulty with sit to stand, and difficulty with stairs. Note, this applies to all diagnoses. Remember, no questions specific to a diagnosis were included. The focus is on the person. Conversely, if our patient is doing well, we can also note that. This shows an example of a patient who scored 60, 10 points or 1 standard deviation above the U.S. average. This indicates that person's ability was equal or better than 84% of the U.S. population. Likely, if this person is seeking care, psychosocial domains may be more important than physical ability. Finally, because the PROMIS scales are person-centered rather than specific to a disease, they can be used to assess overall team or department performance. Here we show an example of physical function at the initial evaluation for 200 patients. Note that average is 0.6 standard deviation below the U.S. norm. While many patients have needs associated with low physical function, noted in the shift of the scores toward lower physical ability, some patients are functioning quite well, 1 to 2 standard deviations above average. These higher functioning patients may need fewer visits and likely have needs focused on psychosocial issues. Here we look at the prevalence of 3 PROMIS measures at the initial evaluation of patients attending a rural outpatient orthopedic clinic. Focus on the red, which indicates a half standard deviation or more below the U.S. average. We see physical function, fatigue, and self-efficacy. These low symptoms are, give or take, equally common among patients. When we look at the tendency for patients to present with multiple symptoms in the red, or worse than the U.S. average, the first thing you notice is that around 20% have no symptoms in the red. And then about 20% have symptoms that are restricted to physical function and pain, which demonstrates that the vast majority of patients have symptoms that either include other health domains like fatigue and self-efficacy in addition to physical function and pain. So what we're learning is that patients are complicated. An open question then becomes, by addressing some of these other symptoms or health domains, can we have a bigger impact with our patients? In subsequent videos, we'll cover specific algorithms of how to use the PROMIS scales of physical function, fatigue, self-efficacy, and satisfaction with participation in social role measures to evaluate and determine which treatments we employ clinically. In summary, using the PROMIS measures provide a new focus on measuring the person rather than specific disease effects and provides a new appreciation for severity, both strongly influencing treatment decisions. Let's illustrate the person-centered biopsychosocial approach to knee osteoarthritis. The focus is on pain and function, typical musculoskeletal issues for patients. Yet data tells us that common comorbidities such as weight gain, diabetes, cardiovascular problems are all aggravated by knee osteoarthritis. These are bigger medical issues than the knee problem. A person-centered biopsychosocial approach focuses on improving confidence, to increase physical activity through participation in a variety of social goals. To implement this bio-psychosocial care required a new focus on person-centered goals as compared to patient or disease-centered. A good start is to frame goals in the context of important social interactions of the patient. Social function can be defined by interactions of the person with family, friends, work, and leisure. What we learned is that by defining measurable goals informed through motivational interviewing and cognitive therapy usually engages patients and motivates them. Second, the focus on these specific skills help define what skills and theories therapists might seek out to improve their individual patient outcomes. For biomedical, our current skills serve us well and help us address problems in the physical function and fatigue in terms of aerobic capacity. However, in the psychological domain, fatigue and self-efficacy are the key measures. High fatigue is frequently associated with sleep and depression problems, as well as aerobic capacity. This led us to develop skills in sleep and collaborations with behavior for depression. The focus on self-efficacy led us to physiologic models of phobias and motivation. This included graded exposure, skill mastery, cognitive behavioral techniques, and more recently, brief psychological interventions like focused acceptance commitment theory or FACT, with the common goal to apply these psychological interventions to directly challenge negative beliefs and attitudes about physical activity. Finally, these same skills translate to assist therapists discuss goals that are meaningful to patients in terms of social interactions with family, friends, work, and leisure activities. To illustrate the approach at its best, here we review and show a video of a remarkable case. The patient was a 55-year-old former police officer who was involved in a crash that left him with chronic pain. After seeing an assortment of 7 providers over 8 years, he became inactive, gained weight, and was diagnosed with hypertension. Prior to initiating treatment, the therapist examined his PROMIS scores, which all indicated a standard deviation worse than U.S. average, which is equivalent to 16% of the population. Some important notes before we listen to some clips of him talking about his experience is that his fatigue scores increased to 66 in the moderate to severe range on the 3rd visit, and he reported falling asleep during the day. This initiated a referral to primary care with recommendation for further sleep studies. The patient returned 4 to 5 months later, having lost 60 pounds with the goal of returning to a normal life. Let's listen to the patient and provider separately.
So then we worked for a few sessions, which lasted over several months. And then we went on a little bit of a break, and then you came back for more, but this time you had lost 63 pounds.
Mm-hmm.
What made you change your health habits?
You did.
Okay.
So one of the things that happened after the crash was I literally gained over I think it was 70 some odd pounds, and I know that didn't help with the recovery, but when you can't do anything, at least for me, I didn't have any ambition or reason to try to do anything different because I couldn't do anything, so why even try? And the reason why I stopped, or the reason I actually, it says, yeah, a little light bulb went on. You actually told me that, and I don't know if you remember this or not, you actually told me that I think I can, if we can get you to have a normal life again. And that was so far removed from everything that I thought could happen, that it just, like I said, clicked like a light bulb and going, if I can have a normal life again, probably help if I lose weight, and the physical therapy part would actually get better, easier as well. So that was it. You did a full, what I call a complete exam and a complete history of me before you decided what you were going to want me to do. And you were literally the only one that ever did that. So you had your approach and your questions were totally different than anybody else's.
Okay.
I'm trying to do a lot more. I'm actually to a point now where I literally just got back from scuba diving with great white sharks. Haven't been able to scuba dive in 7-8 years. And so my outlook and the things that I know that I can do now are a lot more than I used to be able to do.
So what does a person-centered care look like for you, Liz?
That's a good question.
Yep.
I was heavy manual therapy trained. And so I was trained to find the source of pain. And so once I graduated in my first job, I realized that I can't find the source of pain for most patients, and it drove me crazy. And I got frustrated, and I knew that somewhere I wanted to get better, and I wanted to provide better care, and I didn't quite understand how that looked like. Once PROMIS hit, I think it made things a lot more clear for me because I realized what I was missing.
Yeah.
And so when you look at person-centered care, I wasn't asking the right questions. Maybe it was due to fear. I was uncomfortable in asking certain questions. I thought that, who asks about fatigue? That's not in my scope. They can talk about that with their doctor. I'm here to treat their pain and find their source. And so once I came to that realization and realized that it really is more about the person sitting in front of me, that is where it changed.
What did the PROMIS tell you about the patient, Liz?
The PROMIS allowed me to see a deeper side into the patient. His history was that he was a cop. And so he would never have told me the certain things that the PROMIS allowed me to see. And so I went after self-efficacy first because that was really low. He really had no hope. I mean, he had seen the 7 providers, and so what makes me the one that's actually going to work? And he was just so desperate.
So how does the PROMIS score help you with that then?
I mean, with follow-up PROMIS visits or visits with PROMIS, if you start seeing a change in self-efficacy, the moment you start seeing a change, you know that they can reach it. So it's all about realizing, if your self-efficacy was low 30s, but you come back in that second visit or third visit and now we're in 40s, maybe there's some buy-in, or maybe there's some kind of belief that maybe I can do a little bit more than what I thought I could.
So tell me a little bit then about it sounds like his social roles changed.
Right.
Can you kind of talk about what the transformation you saw in the patient with his social roles?
Yeah, I mean, he was in so much pain initially that really it was effort for him to even leave his house. So as he realized that he could do more and more, he would tell me more about he has daughters, and so he would have daddy-daughter date, and that became more and more frequent as he was starting to feel a lot better, and they would start doing more. It wouldn't just be meeting somewhere to eat something, they'd actually go do something. And I think he kept pushing until he realized, hey, maybe I can do this.
I mean, that's really a remarkable case. We had no idea we'd be presenting a case like this when we started down this road of the Beyond Bio-psychosocial approach. But we can't help but be happy and celebrate. And I think the keys to us getting to this point in terms of exploring these kinds of new treatments is really the PROMIS framework. It's really redirected us toward being person-centered. It's really changed how we see how sick patients are, and that has all to do with how severity has been redefined for us by these scales. And then, we've really had to kind of measure up and admit that by becoming more biopsychosocial, maybe we can really have a bigger impact on our patients. I think what really has us excited right now is to share this approach with other people and therapists and get their feedback and see what they do with this same framework. And we're excited to move forward with that. So this last slide, we're trying to illustrate here just the uncertainty of going forward when you're really in a new area, and how training can support you. And so we're committed to kind of sharing full on our experiences with this approach, to really move it forward, and then really get see it take off and become different things for different institutions and people using this approach. That's it for the first introductory session to the Beyond Bio-psychosocial program. We look forward to making these presentations interesting and informative, and working with your team on a biopsychosocial approach to care.